My name is William Sawfeld. I'm a nurse practitioner in Lincoln, Nebraska, and today I'll be talking to you about a few issues with psoriatic arthritis, and particularly how does the design of the guselkumab APEX trial differ from DISCOVER-2 to enrich for structural damage. And essentially, the key changes to the APEX trial, specifically enriching for patients at higher risk of structural damage compared with DISCOVER-2, was that there was mandatory radiographic damage at baseline. So with the APEX trial, it required greater or equal to 2 erosions that were present on screening with hand and foot radiography, whereas DISCOVER-2, it was a bio-naive trial with guselkumab and did not require baseline erosions. There were lower joint count thresholds, but still enforced systemic inflammation that APEX enrolled greater than 3 swollen and tender joints plus elevated CRPs, where DISCOVER-2 required greater than 5 swollen tender and a CRP of greater than 0.6. The APEX criterion combined active synovitis with systemic inflammation while allowing for inclusion of the patients who may have already had structural damage despite lower joint counts. So the biologic experienced exclusion was maintained, but prior therapy in the context differed. Both focused on patients with inadequate response to non-biologic therapies, meaning like conventional synthetic DMARDs such as methotrexate. APEX selected those patients with risk factors for progression, which is why they had erosions on baseline hand and foot radiographies, along with elevated CRPs, explicitly stated in the protocols. So they were basically looking at the patient population that was already at risk for radiographic progression and more severe disease. So the primary and major secondary endpoints were a little bit different. In APEX, the change in PSA modified van der Heide sharp score at week 24 was the major secondary endpoint, with the assumptions aimed at detecting differences in structural progression, again, that radiographic damage. DISCOVER-2 evaluated radiographic progression, but was not supported by baseline erosions. And so collectively, the strategy in APEX was that the baseline erosions plus elevated CRP and activated synovitis was chosen to better identify those patients that were at a risk for structural damage. And they were looking to see whether or not their treatment would detect inhibition of radiographic progression relative to DISCOVER-2. And it was a phase 3B trial that was followed up from that. And for more information on this, you can go to the RAP website or download the RAP ACE app.